Guys, welcome and let's focus on mechanical ventilation. Guys, have you wondered when someone is having a problem with breathing, they can't be able to get enough oxygen in the body and they can't be able to remove the carbon dioxide in the body? What happens? The breathing system is not working. So, for that case, we normally put this patient on a vent. So, we refer to it commonly as mechanical ventilation. So a mechanical ventilator is simply a machine that will take up your work of breathing when you are not able to breathe on your own. So in this case, you're going to have an air source where the air from the source is going to be delivered to the mechanical ventilator. Then it is the work of the mechanical ventilator now to deliver this oxygen or air enhanced with oxygen to the person, to the patient, and this is normally happens through endotracheal tube. Normally, the endotracheal tube will go through the patient's mouth into the windpipe, while the nasogastric tube is going to go through the nose into the stomach. So the mechanical ventilator is just to deliver this enhanced air with enhanced oxygen uh, through the tubes to the patient airway. So equally again, carbon dioxide from the patient will also be eliminated from the patient, and in this case will at least will be supporting the breathing system of the patient. So mechanical ventilation, or simply we say positive pressure, we know we are going to use a positive pressure device to generate a controlled flow of oxygen into and out of the lungs. The aim is just to maintain alveolar ventilation while ensuring carbon dioxide elimination. So most ventilators you find they are positive pressure ventilators, so delivered to the airways. So air is delivered to the airways through an endotracheal tube or tracheostomy tube, and it can be categorized according to the process, so that starts or stops the ventilation. So in this case of mechanical ventilation, we normally have four phases. Phase one is the trigger, inspiratory, cycling, and expiratory. Okay, we normally call it ties. Okay, ties. So in trigger initiation, you find that initiation of an elation will be triggered by an effort from the patient or by the set parameters by the mechanical vent. So what initiates the breathing? It could be the patient or the parameters that have been set in this mechanical ventilator. And then we have now the inspiratory phase where we now deliver inspired breath to the patient. Then it goes now to the cycling phase, and this is where we have a brief moment where inhalation has just ceased, but before exhalation has begun. So we also refer to it as termination of inspiration. Then lastly, we have now the expiratory phase where we have passive exhalation of air from the patient. It's called the expiratory phase. This enables the removal or the elimination of carbon dioxide. So we have volume modes, and we have four major one. Number one, we have the CMV. This is controlled mechanical ventilation, and is a very important procedure. It's majorly used in GPS, the Guillain-Barre syndrome. Guys, a link on Guillain-Barre syndrome will be popping up. You can review this process, which involves this condition, which involves paralysis of muscles, starting from the 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 inferior side traveling to the superior direction. So the CMV is a mode where the vent will deliver a set number of breaths per minute, and each breath is fully controlled by the machine. That's why it referred to is as controlled mechanical ventilator. So the machine is the one that is doing the control. So the patient has little or no control over the respiratory efforts during the CMV, and GBS we've said it will be it's one of the situations where we normally use or necessitates mechanical ventilation, This is majorly due to muscle weakness and respiratory failure. Next, we have the assist control. SC, assist, it means the machine is assisting, guys, just from the word. So in this mode, we have the ventilator is delivering a preset volume at a set rate. If the patient initiates a breath on their own, the vent will assist. The vent will provide support to ensure that the preset tidal volume is delivered. So SC is commonly used when the patient is unable to sustain sufficient spontaneous breathing. So the machine assists you. Then number three, we have the intermittent and continuous mandatory ventilation, IMV and CMV. So in this case, you find these words could be used interchangeably, but in this case, you find the vent delivers mandatory breaths at a set rate. So in IMV, intermittent mandatory ventilation, the patient can also initiate additional breaths between the mandatory breaths, while in CMV, that is the continuous mandatory ventilation, the patient has little or no control over the timing of additional breath. So that gives us an opportunity to go to number four. So number four is the CIMV, the synchronized intermittent mandatory ventilation. So in this mode, the ventilator will deliver a set number of mandatory breaths per minute. It's similar to CMV, however, the patient can also take spontaneous breaths between the mandatory breaths. So the ventilator synchronizes its support with the patient's own efforts, allowing for a more natural breathing patterns and used during the weaning process when the patient is transitioning to a more spontaneous breathing. So in weaning, which volume mode do we use? This SIMV. All right. Next, we have the different types of breaths delivered. So we could have the control set where we have the set inspiratory rate. We say the inspiratory rate or volume assist. So this is patient assisted breath with set inspiratory flow rate. Pressured control, where we have now the ventilator initiated breath with a pressure limit. And lastly, we have now the pressure assist, where the patient initiates the breath with a pressure limit. So controlled breath, there is no work. The ventilator does all the work. While assist, the patient can start the work, then the ventilator takes over the work. Supported breath, this is where the patient is able to do some or most of the work. So the ventilator assists to finish the work. Okay, that's why it's pressure support. Okay, so ventilation, you find that causes inspiration while increasing the tidal volume. Okay, it helps uh, increase the tidal volume, but doesn't ensure adequate gas exchange. So we also have inspiratory cycles, which do vary in volume, pressure, or time. So like for the volume cycle, ventilator is the most common one that is used, and it normally delivers a preset volume of air at each time, regardless of the amount of lung resistance. When you compare with the second one, which is pressure circled ventilator, this generates flow until the machine reaches a preset pressure regardless of the volume delivered or the time required to achieve the pressure. Lastly, the time cycled ventilator, it generates flow of preset amount of time. We have several indications of mechanical ventilation. As you know, positive pressure ventilation, it could be indicated for a number of patients with apnea, ventilatory failure, impending failure, severe hypoxemia, respiratory muscle fatigue that has been brought about with different uh, medical conditions. So this could have resulted maybe from acute or chronic lung injury, laryngeal angioedema, neurological disorders, trauma, chemical or medical respiratory depressants such as the sedation, anesthesia, opioids, multiple organ dysfunction syndrome, or such diseases also states such as the cardiogenic pulmonary edema, pulmonary hemorrhage, pulmonary thromboembolism, acute, severe asthma, sepsis, and septic shock. All of them are going to present some symptoms that will warrant the need for mechanical ventilation. So the goal of ventilation will be to maintain adequate alveolar ventilation and oxygenation, to correct hypoxemia and acid-base balance and decrease the work of breathing while just providing adequate respiration and respiratory muscle rest and minimizing complication for the patient. So a practitioner, a physician may prescribe intermittent administration or continuous fusion of a sedative or pain medication and a paralytic agent, and the major role is you just want to decrease the patient's work of breathing and now to enable the ventilator to work effectively. So a practitioner orders mechanical ventilation, then we'll set the ventilatory parameters in collaboration with the respiratory therapist just to maintain the pH, partial pressures of arterial carbon 4 oxide and partial pressure of oxygen and arterial oxygen saturation. The practitioner, the respiratory therapist, and the nurse must collect and manage the moment to moment ventilator needs of the patient. So the nurse must have demonstrated the knowledge and competence in assessing, monitoring the ongoing care of a patient on a vent, as well as the basic ventilator mechanism of action. So the procedure involves adhering to the standard precautions like putting on the gloves and other personal protective equipments, then connecting the artificial air to the ventilator. Remember, the air has to come from the source to the mechanical ventilator, the ventilator now to deliver the oxygen to the patient via the endotracheal tube. Okay, so you observe a bilateral chest expansion and auscultate for breath sounds. Then you make sure that the vent alarm limits are set appropriately and that the alarms are turned on and audible. So ventilator alarms, they normally alert the staff just for any potentially hazardous condition and changes in the patient status. So as a nurse, you keep monitoring the patient's ABGs values after initial ventilator setup, after any changes in the ventilator settings, and as the patient clinical condition warrants. You have to adjust the ventilator setting depending on the ABG analysis, orders, and protocols, and you check the ventilator tubing for condensation. You drain the condensate into a collection trap and empty. Don't drain the condensate into a humidifier, guys. So you have to monitor the inline thermometer to ensure that the temperature of the air delivered is close to the body temperature. When you are monitoring the vital signs, you have to count the spontaneous and the ventilator delivered breaths. You change, clean, or dispose of ventilator tubings and equipments, and this should be done every 48 to 72 hours. And the major reason is to reduce the risk of bacterial contamination. Also provide oral care to decrease ventilator associated pneumonia. So you advise at least to clean twice a day in that case. So when ordered, you have to begin weaning the patient from the ventilator, and that's when you use the intermittent, okay, vent. So the pressure alarms, we have different causes for these alarms. We can start with the with the low alarm. You find it could be a disconnection of the endotracheal tube from the ventilator. So when they are disconnected, you have to reconnect the ET to the endotracheal tube to the ventilator. Another cause for low alarm, it could be displacement of the endotracheal tube above the vocal cords or extubation of the tracheostomy. So in this case, you as a nurse, you have to check the endotracheal tube placement and reposition it if necessary. If extubation or displacement has occurred, you immediately ventilate the patient manually and notify the physician. Another cause for the low alarm, it could be leaking tidal volume from the low curve, that is from the uninflated or ruptured curve, or leak in the curve or one of the one-way wave. So your role is to listen for a whooshing sound around the ET tube indicating an air leak. If you hear one, you have to check the curve pressure. If you can't maintain pressure, you notify the physician who may need to insert a new endotracheal tube. Another cause is a ventilator malfunction. You have to disconnect the patient from the vent and ventilate the patient manually if necessary. You have to obtain another ventilator. Lastly, we have the leak in the ventilator circulatory, that is from loose connection or hole in the tubing, loss of temperature sensitive device or cracked humidification device. So you, as a nurse, you have to make sure that all connections are intact. Check for holes or leaks in the tubing and replace it if necessary. Check the humidification device and replace if it is cracked. What about the causes of high alarm? Okay, high alarm could be caused by increased air pressure or decreased lung compliance caused by worsening disease. So you as a nurse you have to auscultate the breath sound for evidence of increasing lung consolidation, barotrauma or wheezing, and you notify the physician. Another cause maybe could be the patient could be biting on the oral endotracheal tube. So if possible, you can insert a bite block, okay, and you can also consider pain medication or sedation if possible, so as to allow the bend to have a maximum time to work and and assist the patient. Another reason for the high alarm could be secretions in the airway. So you have to look for the secretion in the airway. You suction the patient's airway and have the patient cough to remove the secretion if necessary. Another reason for the high could be the condensate in the large bore tubing. So you check the tubing for the condensate and you drain the condensate from the tubing as necessary. Intubation of the right main stem bronchus could be another reason. You have to auscultate for diminished or absent breath sounds on the left lung fields, right? Patient coughing or gagging or attempting to talk could also be another cause for high alarm. So you have to get closer and see if the patient is attempting to do so. So you check the endotracheal tube position. If it has been displaced, you notify the physician who may need to reposition it. Another cause could be chest wall resistance, failure of high pressure relief valve, or bronchospasm. So, in chest wall resistance, if the patient's breathing becomes asynchronous with the ventilator, the physician may order sedative because this is like somebody, it's like the patient is fighting the vent, so they have to be synchronous. They have to happen at the same time. If there is failure of high pressure relief valve, you have to reposition the patient to improve the chest expansion, administer them and prescribed analgesics if necessary, following safe medication administration practices, and you replace faulty equipment. In case of bronchospasm, you assess the patient to try to determine the cause. You could report your findings to the practitioner and treat the patient as ordered. So we have several complications of mechanical ventilation. It's not a clean procedure as per se. Carrying out this procedure could result into several even life-threatening complications like atelectasis, tension pneumothorax, which can be so deadly. So, like for the atelectasis, you have to assess for atelectasis by evaluating for decreased or bronchial breath sounds, localized dullness to the percussion, check for increased breathing effort, check for tracheal deviation or localized consolidation on chest x-ray, increased peak inspiratory pressure, decreased compliance, decreased partial pressure of carbon of oxygen or oxygen saturation. So if you detect there are signs of atelectasis, you have to do the following. You have to suction the patient's airway when needed. Remember, for you to suction, you have to pre-oxygenate, again suction, again pre-oxygenate. Okay. So reposition the patient at least every 2 hours and then obtain an X-ray as ordered to confirm the localized consolidation and position of the endotracheal tube. So as a nurse, you have to collaborate with the physician and the respiratory therapist to adjust the ventilator setting as needed. And if the ventilator intervention you have to apply, they have to include techniques that will increase the hyperinflation, the hyperventilation, and oxygen concentration. Remember, atelectasis is a collapsed lung. All right. Next is the cardiovascular depression. So this is secondary to positive pressure ventilation and presents as reduced venous return or reduced left ventricular output due to shifting of the ventricular septum to the left and increased right ventricular afterload because of increased pulmonary vascular resistance. So to assess for signs and symptoms of cardiovascular depression, you observe for decreased blood pressure, tachycardia or bradycardia, increased capillary refill time, weak peripheral pulses, the presence of arrhythmias, and decrease in pulse pressure. If you observe signs and symptoms of cardiovascular depression, you have to reduce the positive pressure ventilation related changes in the intrathoracic pressure by delivering the PIP necessary for adequate ventilation and optimizing the inspiratory to expiratory ratio. And also you have to collaborate with the physician to change the ventilator setting so as to achieve an optimum ventilation with decreased cardiovascular complication. They could also have another complication is inadequate breathing patterns and inadequate ventilation. So to assess this one, you observe for increased work of breathing, shallow, irregular or agonal respirations, apnea, tachypnea or dyspnea, intercostal or substernal, abdominal or tracheal retractions, nasal flaring, pursed-lipped breathing, central cyanosis. We could also have minimal chest excursion, synchrony of respiration to ventilation. Patient could present with chain stroke breathing patterns, a stacking breathing pattern, abdominal breathing, or a symmetrical chest expansion, the seesaw breathing pattern, or even irregular breathing. So if you have to observe this one, you have to now, as a nurse, you have to examine the ventilator tubing to ensure that it's assembled properly and has no loose, kinked, or clamped connection that may cause obstruction. You have to confirm the position of the endotracheal tube by direct observation or obtain an X-ray as ordered. Then suction the patient's airway as indicated just to clear the airway of plugs and other obstruction. Reposition the patient every 2 hours or more frequently as indicated to prevent dependent fluid buildup. You ensure that the patient is comfortable and is sedated properly if necessary because pain or discomfort is likely to result in changes in the patient's respiratory pattern. So if they're in pain, could be another cause. Keep in mind that a patient on mechanical ventilation must depend on the nurse to meet psychosocial and physical needs. So you must be there for the patient. Anxiety related to the ability to communicate and dependence to others may increase resistance to ventilation. So you have to talk to the patient so that they are aware of this one. And it should be normal for them so that they can at least cooperate and get the best out of the vent. Pulmonary barotrauma, and this could be caused because of increased air resistance or decreased lung compliance from conditions such as asthma, the COPD, the chronic interstitial lung disease, acute respiratory disease syndrome, pneumonia, or lung lesions. And after invasive thoracic procedures such as the central venous access catheter placement and the thoracentesis. Another could be because of high pressure may be necessary just to deliver desired tidal volume, but you find that they may increase the risk of pulmonary barotrauma. So this barotrauma can result in pneumothorax, pneumomediastinum, pneumoperitoneum, pneumopericardium, and subcutaneous emphysema. So to assess for pulmonary barotrauma, the nurse will have to observe the patient for acutely increase the PIP, you acutely decreased partial pressure of oxygen or oxygen saturation, and acutely decreased airway compliance. So you have to auscultate the patient's lungs for acutely decreased or absent breath sounds in specific area or lobe. Then assess the patient for acute changes in vital signs, acute dyspnea, hypoxemia related restlessness, agitation and panic, new onset of subcutaneous emphysema. If you do suspect that the patient is having pulmonary barotrauma, Then you have to notify the physician to obtain an order for an X-ray to confirm this suspicion. You know that you can reduce the PP ventilation barotrauma by decreasing or optimizing the PIP and decreasing positive end expiratory pressure, optimizing the patient's comfort to allow synchrony of the patient to the vent breathing and ensuring proper endotracheal tube placement and decompressing pleural or mediastinal air. You have lastly to be aware of the invasive surgical intervention are required to correct most of the complication from the pulmonary trauma. Another complication is the arterial blood gas analysis. Guys, a link will be popping up showing you how to calculate the ABGs, okay, using the matching partner technique. So abnormal values in the patient's ABGs analysis could indicate either acidosis, alkalosis, or inadequate oxygenation. So you have to monitor the patient's ABGs after initial ventilator setup, usually 20 to 30 minutes. After the changes in the ventilator setting and as the patient's clinical condition indicates to determine whether the patient is adequately ventilated and to avoid oxygen toxicity. So if you obtain abnormal ABG values, then you have to notify the patient and be prepared to adjust ventilator settings based on the ABG analysis and practitioner's orders. Another complication is ventilator-associated pneumonia. So you have to evaluate your patient for the presence of the purulent or discolored secretions. Okay, dyspnea or increased inspiratory pressure, reduced tidal volume, fever, and other changes in vital sign. You also try to evaluate any culture that has been obtained, and if you observe that the signs and symptoms of ventilator associated pneumonia are present, you have to quickly notify the physician, then you obtain the sputum cultures as ordered, obtain chest imaging as ordered, then administer antibiotic therapy following safe medication administration practices as orders if the cultures are positive. So what are you supposed to do before this treatment, before the mechanical ventilation? Well, in most facilities, respiratory therapists are the one who are charged with setting up and maintaining the ventilator. So you simply add sterile distilled water to the humidifier according to the manufacturer's instructions and connect the vent to the appropriate gas source. Okay, so you make sure that the humidifier is filled with sterile distilled water and that the heated humidifier is set to deliver an inspired gas temperature of greater than or equal to 34 degrees Celsius but less than 41 degrees Celsius at this circuit Y-piece and provide a minimum of about 33 milligrams per liter of water vapor. Then you attach a capnography device to measure carbon 4 oxide level to confirm placement of the endotracheal tube, to detect disconnection from the ventilator and to detect complication. Make sure that emergency equipment is functioning properly and readily available in case the ventilator malfunctions or the patient is extubated accidentally. What about after the procedure? So if the problem can't be identified, you disconnect the patient from the ventilator and use a handheld resuscitation bag to manually ventilate the patient. Then you make sure that the emergency equipment, including a working manual resuscitation bag connected to oxygen, is readily available at the patient bedside. You institute measures to reduce the risk for ventilator-associated pneumonia. So in this case, you have to maintain the patient's head to of the bed upright at around 30 to 45 degrees angle, and this is just to prevent aspiration of oral secretions unless it's contraindicated. Guys, a link will be popping up on the different body positioning. Okay, this is just but one of them. Okay, Another measure that you're supposed to carry out to ensure that you prevent this ventilator-associated pneumonia, you have to suction the patient's airway when necessary. To maintain airway patency by removing accumulated pulmonary secretions. And then you have to also, before performing suctioning, we've said you have to hyperoxygenate the patient as needed with 100% oxygen for around 30 to 60 seconds. Then you suction the patient with a closed suction catheter and limit suctioning to only 15 seconds. So after suctioning again, you have to hyperoxygenate the patient for at least a minute using the same equipment that you used before suctioning. Also, in addition, we are supposed to provide oral care at least twice per day, including brushing of the teeth, the tongue and the gums. In addition, you have to perform strict hand washing and use aseptic technique when suctioning, and ensure sedation vacations as ordered so that it's not continuous. Assess the patient's ability to be extubated. You administer prophylaxis to prevent peptic ulcer disease. It could be the proton pump inhibitors or the H2 blockers. You also administer prophylaxis to prevent deep venous thrombosis as prescribed. You can use oral chlorhexidine gluconate to rinse as prescribed to reduce colonization of the oropharynx. So for those patients who are undergoing cardiac surgery, you have used the rinse. You rinse them twice daily before the preoperative period. Okay. You have to use the endotracheal tube with a dorsal lumen above the endotracheal cuff for continuous subglottal suction. Then you have to change, clean, and dispose of the ventilator tubing and equipment when it's visibly soiled or malfunctioning or at an interval determined by the facility. You can use an oral moisturizer on the lips and oral mucosa every 2 to 4 hours just to reduce oral inflammation and improve oral health. Then record the depth of the endotracheal tube by marking it at the teeth and then secure it with a tape or a commercial holder device. So you be assess and record the depth every 4 hours. Just determine whether the tube has become displaced. You have to confirm initial and ongoing tube placement by assessing for equal breath sounds and chest rise, okay, equal chest rise and fall with the use of commercial carbon dioxide detector. You assess for continued proper placement by auscultating for lung sounds and with other assessing parameters. How about monitoring the patient's vital signs, the respiratory status, and the ABG values? And in addition, you're providing emotional support to reduce anxiety even if the patient is unresponsive. Unless contraindicated, you have to turn the patient from side to side every 1 to 2 hours and assist with active or perform passive range of motion exercise or assist with early mobilization. If permitted, you can position the patient upright at regular intervals and then provide personal hygiene, such as, as washing the face, bathing, shampooing the hair, and shaving. Provide distractions as appropriate, such as access to music, audiobooks, and arrange for visits from families, friends as desired by the patient. Remember, these patients are at high risk of developing peptic ulcers, and the stress is so significant. So, such cases or such distraction could help the patient. When asking questions about that require yes or no response, you instruct the patient to use signals such as blinking or using the thumbs up sign, smiling, or using communication boards. Okay, because there is a problem. Also, could be have anxiety related to lack of inappropriate way to do communication. So you have to at least talk to the patient to ensure that this is done. You follow infection prevention techniques such as performing hand hygiene, providing oral care, positioning the patient with the head elevated 30 to 45 degrees. And then when caring for a patient receiving mechanical ventilation, this will help reduce this ventilator associated pneumonia. You have to prevent the condensation in the tubing from flowing into the lungs. Then provide care to the patient's artificial airway as needed. Assessing peripheral circulation is also required. Then monitoring the input output. You watch for the signs and symptoms of fluid volume excess or dehydration. Assess for skin turgor and check dependent areas for edema. You have to establish a method of communication such as a communication board that we have said by nodding or writing board. Then give a sedative or neuromuscular drug as prescribed to relax the patient and prevent them from fighting the veins. Okay, reassure the patient and the family that paralysis is temporal. So you closely observe a patient who is unable to breathe or talk and make sure that emergency equipment is readily available so that in case the vent fails, you can actually manually ventilate your patient. You explain the procedures and ensure patient safety and make sure that the patient gets adequate rest and sleep. Cluster care activities to promote rest for that case. Provide subdued lighting and low noise and restrict staff movement around the patient. This to minimize exposure to environmental stimuli. And then observe for signs of hypoxia when weaning the patient, and with the patient's input, you schedule weaning around the daily regimen. So as weaning progresses, you encourage the patient to get out of the bed, so to be ambulatory, and then suggest diversional activities such as watching TV, listening to music, so that to take the patient's mind off the breathing. In teaching, you have to teach. Teaching should be family centered, and you need to be sure to include the family and the caregiver when appropriate. You instruct the patient on the methods of communication, just as we said before. And for those patients who will be using a ventilator at home, you have to provide a teaching plan that covers ventilator care and settings, artificial airway care, sanctioning, hand hygiene routine, vaccines per the physician's recommendation, and avoiding secondhand smoke, respiratory therapy, communication, nutrition, therapeutic exercise, signs and symptoms of infection, troubleshooting, minor equipment malfunctioning. So you need to have the family member or caregiver who, so that demonstrate the ability to use the equipment in that case. And then you refer the patient to a home agency or a durable mechanical medical equipment vendor. You have to refer the patients to available community resources. So guys, those are the different types of vents, and those are different types of complications that come up as a result of mechanical ventilation. So remember, mechanical ventilation has four phases. We have the trigger phase, inspiratory phase, cycling phase, and expiratory phase. We normally abbreviate it as what? TICE. Okay? Thank you so much, guys. See you again.